Okay, folks. Yeah.
Thanks very much.
Welcome to Friday's report out, which of course our opportunity to share Leeds improvement method and what we've been doing, and special guest today, which is excellent. So we're very grateful to you, Secretary of State, for coming along to share the work that we've been doing, and you've given us a lot of your time. We've seen some of the work that we do here, and just by way of introduction, before I perhaps ask you to maybe say a few words, we always do this on Friday, lunchtime. We put up our pyramid with the patient at the top, our vision, our goals, and we talked about the Leeds way yesterday, which is all about our culture and the way we engage everyone. And I think today you see the scale and scope of the activities that go on through the Leeds improvement method, which underpins the pyramid in terms of continuous improvement, involving colleagues at the front line. And everyone in this room is involved in some shape or form in that work. And that work has run across the whole trust in a range of different service areas and is really changing the way we work and the impact on patients. So I'll pause there because before we get into this, because we're going to see several report outs, but we do know you have to get away to another engagement, but perhaps an opportunity for you to...
Sure. Well, brilliant. Thanks, Julian. I came here because as 3 months into the job of being Secretary of State, I had kept hearing from different people in different parts of the system that you've got to go to Leeds because they're getting it right, and so I thought I'd come. So I've spent a couple of days. I arrived yesterday lunchtime, and in particular, I heard about the technology and the Leeds Care Record and all of the interaction with the rest of the wider health system. But the thing I've really been struck by, which I didn't know about in advance, is this method of continuous improvement. And you didn't know this, but I've just been in with a dozen or so of junior doctors and nurses, and they were, I said, have you got permission to improve things? And they sort of bit my hand off. Yes, yeah, it's fantastic. It's one of the best things about working here. So I've really learned a lot about the different, about a whole series of different things that you're doing. And I think it's brilliant. I'm also here, obviously, I'm always keep my ears open to things that need to change, things that need to improve. A few of those have come up as well, and I'll take those away. It's a very good moment to have that discussion because we're in the middle of writing the long-term plan with Simon Stevens and the rest of the NHS national leadership, and so this is a really good moment where we need to influence national policy, or in my case, set national policy, and essentially to allow you the capacity to do what you do so well. So it's been brilliant. I'm going to stick around for a
Yeah.
few minutes. I'll just fade into the background if that's okay. Unless you want to, anybody have any burning questions, or do you want to just get on?
Well, we'll kick off and you can see the kind of thing that we do.
Fantastic. And then I'll quietly make my way out.
Fantastic. And thank you very much for your support, Secretary of State, on this. And I think, just as I was saying to you yesterday, just a reminder, and a reminder to us all, because all of you in this room are involved in this, and we've got represented here leaders of clinical services, head nurses, general managers and colleagues from across the Trust. But we are now up to 7,857 staff trained in the Leeds Improvement Method, which is almost half of the organisation. So I think we're reaching that tipping point now in terms of the scale and scope of the training. And you can see some of the other areas where we've made real progress. And of course, every month at the guiding board, when I sit down with NHSI, colleagues with the other trusts that are involved in this work, we talk about how many staff we have trained and so on. But given the scale of what we've got in Leeds, with 18,000 of us, to have this at this level is a real achievement. And thank you to all of you involved in Lead for Leaders, and I still need to do that homework. Well done to all of you that are on track with that. So we're going to start this week's report out with Value Stream 3, Rapid Process Improvement Workshop 4, and I think invite Sarah, Steve, Dawn, Ellie to present.
Hello, my name is Dawn. I am a Senior HR Manager in the Trust, and I was Workshop Lead for this RPIW week. And as you've seen, we're looking at the rehabilitation prescription for patients from neurosurgery. So what that does from the high-level metrics is we're looking at length of stay for patients in neurosurgery, trying to reduce that. Our team lead, Helen Rollet, couldn't be here today, but she spent quite a few weeks out on the Gemba with the neurosciences teams, and we witnessed the time that it takes from identifying that a patient is ready for rehabilitation to the time that that request form, that referral or the rehabilitation prescription takes to get to the centre that it needs to go to. On average, 52 hours, which is a significant period of time for that patient to wait before even the referral is sent. So the team got together, we got the metrics that Helen kindly provided. We were aiming to get that rehabilitation prescription to the receiving organisation within 1 working day. So within the 8 hours that's available to the staff. That was our improvement objective. The other thing that we had feedback on was that the referrals, when they were actually completed and sent, weren't complete. We thought they were completed, but they weren't. So there were significant challenges and defect rates in those referrals, which created a further delay, further examples of staff having to make phone calls, send back, and so on. In terms of takt time, we always try to identify how much time is available to meet the demand of that work. So 8 till 4 is generally the time that we do those prescriptions, and we try to get 1 a day out. And basically that gives us a takt time of 28,800 seconds.
Hello, my name is Steve Wilson. I'm the Clinical Director of the Neuroscience. I was acting as sponsor during the week, but I'm actually here representing Neuraj, who was one of our neurosurgical trainees, who very kindly gave up a week of his clinical time to come and support the team in doing this piece of work. Unfortunately, he's had to be clinical today, so he can't be here. But this value stream map demonstrates the processes involved in getting from the point at which a patient is described as being fit for rehabilitation to that piece of documentation going out to wherever it needs to go. A number of steps involved in that process. Green boxes show the processes themselves. It's important to note that the decision as to whether the patient is for rehabilitation can be made by any member of the team. So it could be a nurse, it could be a therapist, it could be a doctor. But obviously everybody has to be in agreement about that process, about that readiness for rehabilitation. The rehab prescription is quite a lengthy, complex document. It needs to be filled in by lots and lots of different people, and that's represented in there as well. I think for me, the most important two things to remember from this: one, that it's 52.5 hours for this process to go from the left to the right. But the really important thing, I think, are the clouds that you see around the process, which represent areas where the team felt there was lots of opportunity to improve. So those are the waste in this process. This simply demonstrates the actual flow of that information. It's a relatively simple map which goes from around about 4 different areas involving primarily nurses, physiotherapists, and occupational therapists. Doctors are involved in this process, but we'll come to that later. They're not the most important people. The time observation, as Dawn has highlighted, this was done by the team throughout the week, looking at that process, timing all the relevant parts of it, and again, 52 hours. Clearly, we have opportunity to improve on that. I think, again, for me, as the sponsor for the challenge, or sponsor for the process, one of the really important things that came out of it were the ideas, because they're the bits that actually managed to, or give us the opportunity to affect change. And the team produced loads of fantastic ideas around how this process could be improved. These are represented just with a small selection. Some, those who've done Lead for Leaders will know about this. Some are done as diagrams because they use a different part of the brain. Some are just written down as simple ideas because it engages the whole brain by doing it that way. So, one of the key principles that came out from that week through the ideas boards was around definitions, and there are lots of definitions that get bandied around within the NHS. And one of those is the expected date of discharge. And we've spent a lot of time as doctors and nurses trying to tell patients what their expected date of discharge is, but actually if you're going to rehabilitation, that's not very helpful. So the team felt it was really important to define what is rehabilitation. Moving on to the next slide. Possibly more importantly, what does medically fit for rehabilitation mean? Because that's really what's going to drive the readiness for that patient to move to the next phase of their care. Finally, what is therapy fit for rehabilitation? Because actually, patients generally will achieve a medical fitness often some time before they might get to therapy fitness. So those were the key things that came out from this week.
So hello, my name's Sarah Miller. I'm Head of Nursing for Neurosciences. And I was actually the outside eyes to this RPIW week last week. So as you can hear from what Steve and Dawn have said, our importance was around improving the process. We needed to standardise the process for completing the rehabilitation prescription and remove all the waste in the process, that 52 hours. We had a really helpful conversation with Dr. Matt Smith, our rehabilitation consultant, and I think as a team we had so much more respect for the process than before, because we understood, after speaking to him, because we understood that it was a rehabilitation prescription. It's not just a referral form to another organisation. So the common themes that we wanted to address through the standard process description, which we came up with as a team on the Gemba and with our home team, was the lack of ownership and accountability for completing the form, hence the 52-hour window that it was completed in, and making sure that we had one individual that was accountable for completing the form, but with an MDT approach, so we were all doing it at the same time. So we decided to reduce the number of operators in the process and meet at 12:15 after the board round for 3 professionals to complete the form in flow together and then send that off to the referring organisation. And my colleague now is going to talk through the PDS cycles that we went through to achieve that.
Great, so thank you. My name is Neve Dolan and I'm an occupational therapist based on neurosurgery. So once we had the new process identified, it involved completing 3 PDSA forms with the home team and wards L24 and L25 using a time observation form shown on the slide above. As a team, positively we noticed instant benefits, recognised improved communication, collaborative and cohesive working in a timely manner while continually ensuring the quality of the information present in all forms was of a very high standard, and we always checked it out with our colleagues. But most importantly, like what Sarah said, we noticed that there was a sheer reduction in the time used to complete the form. We noticed that there was exceptional value in completing this form at the right time at 12:15 with the right information and of course the right people. We recognise that this form paints the initial picture of each patient's rehabilitation journey, ensuring they get the best care and outcomes in the right environment. The setup time initial at the first PDSA was 15 minutes, and we managed to reduce that down to 8.57 minutes by the end. What was really noted was a positive and successful change in improved team working, which would provide a better outcome for all our patients. Over to Lindsay.
Hello, my name is Lindsay Tate. I'm a physiotherapist who works in neurosciences, so I was part of the team for the RPIW week. So Sarah talked a little bit already about the form, so we had quite a lot of debate during the week about what was the purpose of the form, is it necessary, who should complete it and when. We had quite a lot of helpful discussion with Matt Smith, who's one of our rehab consultants, and he sort of helped us have that light bulb moment that Sarah was talking about, where we realised this is a rehabilitation prescription, not just a referral form that was sent around to another hospital. It needs to represent the patient at a point in time. We started to think about what changes we might need to make to the form. Matt Smith had been to a conference that week, which was the British Society of Rehab Medicine, and was able to tell us about some changes that would be mandated early next year. So we realised that there wasn't much point in making huge changes now, to then change it again would be a bit of a waste. So we went back to the agenda and spoke to the team and completed a 5S process anyway. Most people in the home team fed back that they found the first page of the document, which shows the sort of the guidance on how to complete it, was the bit they felt was quite unclear. They didn't know which units accepted which types of patients. So, for example, someone with an NG tube may be accepted at one hospital and not at another. So that was the bit that we focused on changes. This is the changed form, which hopefully is a lot clearer about how to complete it and what is appropriate to send in terms of information to each hospital. So during the RPIW process, we also completed some process maps. So one for our current state, which is what we were doing before, and one for our future state, which is our new way of working after the initial week of RPIW. When we compare the two, the top one is our current state and the bottom one is our future state. So that one shows a much more streamlined process and a lot fewer people and processes involved. To make the new map at the bottom, we use post-its from the top one. So if you look at what's left on the top one, you can see that's everything that we've managed to remove, so there's quite a bit of waste taken out there. We've got one pink post-it on the bottom one, which represents a waste in the system, and that's the weight. So we have our board round where we decide that patients appropriate for a rehab prescription be completed. That's at 10 o'clock, and then we have a meeting at 12:15 where we actually do the referral and send it. So that might be an area that we focus on for the rest of the time of how we can eliminate that waste. The further ways that we think we can improve are mainly linked around IT, so we think a shared email address or using PPM to give visual cues might make the process smoother and more efficient. But there were things that we weren't able to complete within a week. The things that we put in our parking lot so that we can address those as we complete the process. And then we need to think about the best way of making this sustainable, so change that practice that we can actually continue.
So to recap, the teams worked really hard, not just in the week, but also back on the gamble with the home team. And during that week, we managed to reduce that 52 hours to 2 hours 32. And as Lindsay said, that little pink post-it actually relates to more than 2 hours. But that was on the first hit, let's see if we can reduce the time. We talked about the setup reduction for the whole process, and because the start to the end of the form filling still related to 52 hours, by Friday we managed to reduce that to 8 minutes 57 seconds. So the team have done a really amazing job in getting that reduced. And the work goes on.
Fantastic. Can I stop you there? You finished. If you don't mind, I need to get to that moment. Round of applause.
I got a shoot, but I got a taste for it. This is absolutely brilliant. Fantastic. Thank you.
Folks, I'm going to hand you over to the next call, Secretary of State, to next engagement and see you and all.
Okay. Right. Thanks, everybody.
Desperately wanted to get that.
So just very briefly then, this is the values stream map that we used at the start of the process. As you can see, the highs and lows that we managed to cross off in the RPIW week are many. So we've got a few that we're going to continue to work through in the next 30 and 60 days. Next slide just shows our newspaper, which were our objectives and the actions that we completed in the RPIW week. As you can see, the first 4 actions were green, and then these are the actions that we're going to continue to work towards in the next, for our next 30-day report out. We had an amazing home team, and they were really supportive in the clinical areas.
So the key learning for the week was that there was a new realisation that rehabilitation prescription was absolutely essential, and I think you've heard there was a new respect for that process, and it was really clear at the outset that somebody had to be accountable for that. We talked a lot during the week about balancing clinical priorities with work priorities. And what we meant by that was that we know that medically patients are very poorly, and that's rightly a focus for clinicians, but also those patients that need to be able to exit the hospital, whether that's for rehabilitation or to go home or elsewhere, is equally important, and getting that balance is very difficult. Quality is now being built into the process, so there is a quality check for each element, and that is done the last thing before that form is sent off. We needn't have worried about our ideas being tested on the Gemba because, as you've heard, the home team were very receptive and totally supportive. And the quote at the bottom, I just wanted to share with you because it was Neeraj, our registrar, who was on our team, channeling Donald Trump, said we can make rehabilitation great again, and we will. We'd like to thank our colleagues at Chapel Allerton because during the week they provided some really helpful information for us, and one of our team visited them this week. So the real hard push is from here on in and how that is embedded. Thanks to Steve for stepping in as a sponsor. RPIW team members, everyone contributed massively to the week, as with the home team, and we wanted to thank the people that had been able to be released for that whole week. So stroke physio, HR for releasing myself, head and neck, for releasing Helen, who was the team lead. Really positive feedback from all of our colleagues on this. The advisory team were Matt Smith, who's our rehabilitation consultant, Suzanne Spink from Speech and Language, and Joe Clapham, bed manager, all were available to provide advice during the week. Caroline Dunn was left holding the board, so thank you. And Faye Storin, who works in pathology, she sorted out our room for us at the very last minute, which was great. And last but by no means least, the KPO team for supporting all of this activity and making it possible. Thank you.
So thank you very much, that was brilliant, and I'm really glad that you did it again. I know you reported out last week, but I wasn't here, and I'm sure lots of other people weren't here, so it's been great to hear it again, and well done. I'm going to keep reports out flowing now, and I think our next presenter, Steve Bush, will take any questions at the end.
Yeah,
less than. And indeed, hello. So, hello, my name is Jo, I'm General Manager for Emergency and Specialty Medicine. This is Nadine, my colleague, who's the Sister for Inpatient Flow. We've been asked to speak for a few minutes about Value Stream 5. So Value Stream 5 was about the 14-hour review by a consultant of patients when arriving on the ward as part of their first admission. And it's part of the 7-day standard document, national document. So our focus was on the acute admission floor. So our Gemba was 121 bedded admission floor for elderly medical patients. We have around 80 admissions a day, so that's the scale of the work that we need to deliver on a daily basis. We focused on high-level metrics of the 14-hour standard, and when we began the value stream, or when we, before we did any work on the value stream, we were delivering around a 75% performance on that. So 25% of our patients were reviewed by a consultant within 14 hours. I'm pleased to confirm that we are now delivering around 94%. Some of that is because we've got registrars that are doing the reviews rather than the actual consultant. That's the remaining 6%. So Nadine's going to just do a quick review of the draft improvement work that we did and what key changes we made.
So for us, we did 3 RPIWs. Our first one was in June 2017, where we looked at the time taken to clock a specific patient. We found at the start it took on average 77 minutes to clock one patient. We managed to get this down to 46 minutes. One of the ways that we did this was by identifying a clocking doctor and a clocking computer. So for one of the doctors, they wouldn't have a team of patients. They would just be responsible for clocking and would help pick up the jobs. This meant that they were getting interrupted a lot less. We found at the start that they were getting interrupted on average 49 times per clocking per patient. We managed to get this down to 4. We also looked at ensuring that the patients were actually ready when the doctors were coming to clock them. So one of the ways we did this was the doctor was going to introduce themselves and tell them that we're coming along to clock them shortly. We found that at the start of it, over 20% of the patients were ready to be clocked at the time. Now we've got 100% of our patients that are now ready to be seen once the doctor comes to them. We then moved to look at RPIW2 in November 17. On this, we looked at the ward round itself. From that, we managed to reduce the lead time from 164 minutes to 128 minutes. One of the ways that we did this was the introduction of the ward round perform machine and the introduction of Kanban cards. So if the patient's notes weren't in the slot, you'd know exactly who had them at the time, so you could find them much quicker and much easier. We also managed to reduce the setup time down from 21 minutes to 4 minutes. We then moved on in March 2018 to look at the RPIW3. This looked at the MDT meeting itself. We managed to reduce the lead time for the MDT from 40 minutes to 25 minutes. One of the ways that we did this was by giving the doctors some guidance on what information was required from them. This helped us to ensure that the conversation was value-added for the patients. We also looked at the setup time. We managed to reduce this down from 12 minutes to 4 minutes. One of the ways that we did this was by, at the 9 o'clock safety briefing in the morning, we gave an estimation of what time we'd be ready for the MDT meeting, so that we could ensure that they were on the ward and ready for that time. We also introduced our multi-purpose map, our MPM board. On this, we were able to track the patients that had been seen before starting our MDT meeting. We could ensure that everyone had been seen.
So the good news is the guiding team agreed that we can now transition to operations. So that means that we will be rolling out the learning across all our wards. Certainly in terms of the principal, although the acute wards are slightly different to our specialty wards. Possibly for being bad in a previous life, we've now got another challenge, which is Value Stream 7, which we're hoping to start, which will be focused around the A&E department, the LGI side. So our real challenge as a wider team will be to sustain and continue to improve performance in terms of our 14-hour standard and energise and commit to Value Stream 7. Thank you very much.
Yes. But and also though. I mean, I think throughout that value stream, you also got a change in the way the elderly medicine consultants work as well, didn't you?
Yeah.
And I think the RPIWs helped them to see the value of the consultant assessment or interaction with the patient. And so we now have elderly medicine consultant ward rounds in the evening.
Yeah.
Okay, thank you very much. So, I think now we're having the 150-day report out, again from Value Stream 3, and this is around the ward rounds in neurosurgery. I think Steve and Fiona are reporting out.
Hello, my name is Fiona. I'm senior sister on Ward 25, which is neurosurgery. So our reports out, our RPIW is going to look at ward rounds on Ward 24 and 25. I had a look at the current ward rounds and found that the ward rounds overall were quite rushed with unclear plans, very little patient involvement, and overall poor experience of patients and the ward staff. We were disorganised and undefined start times, and that impacted on the rest of the day, delayed discharges, the nurses and the HPs and the doctors didn't really know what was going on until quite late on in the morning. Our initial plan was to improve quality by ensuring that all information is available before the ward round starts from the MDT via PPM, and including patients in the discussion by starting each ward round interaction with patients with like an introduction, hello, my name is, having a good conversation with the patient, having a look at all the bloods and the obs and things like that, and then ending the discussion by giving an estimated date of discharge so they would know where they were in the sort of discharge process. And we plan to have the ward round recorded by direct dictation onto PPM and to live record the ward round.
So, hello, my name is still Steve Wilson. And the team on the board have done an absolutely phenomenal amount of work on this. And they've managed to complete a significant proportion of the actions from the newspaper. So I'm not going to go through them in any detail, but I'm just going to sort of pick up on a couple of them. So one of the issues that was raised was around training for the junior doctors and how to do the new ward round. The key principle of the Virginia Mason process and Leeds improvement method is that whatever you introduce has to be easier than what was being done before. And that has proved to be a little bit of a problem for us. So there is an ongoing process of training for and teaching for the new doctors. And of course, because the new doctors turn over relatively rapidly, that has to continue to happen. Because whenever we get new doctors in, this is a totally different way of doing ward rounds from stuff they've done in other areas. So that's one of the actions that isn't complete and is going to continue to roll forward. Other issues that we've identified was there was a lot of work put into changing the way that AHPs interacted with PPM in order to create that flow of information so that the doctor could pick it up on the ward round. And it became apparent after days that what we had introduced around AHPs writing on the ward round document within PPM wasn't really working because it wasn't immediately visible on the ward round, people tending to ignore it. So we've stepped back from that, and the nurses are now doing updates from AHPs. But that's not to say that we're abandoning the principles around PPM and what it can do for us. It's a real shame that Hancock left. I know he was really impressed with the PPM platform yesterday, and it's definitely the way forward for us, but it's not quite there in terms of what this process needs to deliver. So that's still a work in progress for us.
So target progress reports. So this gives you sort of what we're doing good and what we're doing not so good. So the good is that we're keeping within the time allocated for ward rounds, which is particularly good this month because all the audited ward rounds this month have been dictated live on a PPM. So even with that in place, we're still keeping the time we've allocated for ward rounds, which is really good. And the other benefit that we hadn't really thought of before from that is that this communication with the patients is quite improved because they're involved in the ward round discussion and they're actually hearing their own entry onto PPM, so they know exactly what the plan is and it's totally transparent, which is good. The bad bits are is that the hello my name still isn't being used as consistently as we'd like. So we've sort of changed the emphasis on who introduces the ward round as a whole, and the nurse in charge of the ward is trying to take more of a role in that, introducing the ward round next to the doctors, so people know who the people are and see them. Another bit not doing so well is the estimated date of discharge, but as was talked about in the previous RPIW our stream, is that we need to think about the language we use on ward round, and that when we talk about estimated discharge, we're also talking about estimated date for when we're ready for rehab, and then updating them where they are in the referral process, as opposed to actually saying that you'll be going home on this day. Sometimes when people press for time and the registrar's going to time, the instant documentation or dictation isn't always done, but it is being done more consistently. The quality is variable depending on if it's been typed actually on ward round or if it's been dictated. But we've had, like I said, this week's lots of success with direct dictation of PPM. And also we've realised that with this introduction from this week that the registrars are going to need some time to get used to using the microphones and sort of being able to multitask and also speak to the patient properly and hello, my name is and estimated discharge. So we're hoping that these things will improve as they get more used to the use of the microphones. So one of the barriers we've had in our RPED is access to hardware and software. So we've made our own noise cancelling microphone, which is actually this week. Other sort of barriers we had were accessing software. We've now got access to using DragonSpeak, which is working not perfectly because it's a busy ward environment with a lot of background noise, but it does work. And like I said, it has worked. We've done 4 ward rounds this week and working fully digital. This slide shows 3 examples of the ward round documentation. So one of the things we identified is that the quality of the documentation wasn't always fantastic. So the first one in the first corner there is an example. When we first started, we were using dictaphones and secretaries were typing up the ward round entries for us. And you can see the input is really good, it's really in depth, it's really useful. And when that stopped and we were going on to the ward round, we typed in by the G doctors actually on the ward round direct into PPM, which is this one on the other side. You can see again, it's not so good, it's not very useful, it's not very in depth. The bottom one is one of the ones we've done this week. This is an example of a dictated entry using the speech text software straight on a PPM. So it's not quite as in depth as the dictaphone entry, but it's still a lot better. So that's what we're striving for, the dictaphone entry, but as the registrars get used to using the software, and the software gets used to them to just learn from your speech and just get better with time, we're hoping that we're aiming for that one in the corner basically.
So I think it's important to emphasise that the team have worked incredibly hard on this and they've had some really tangible successes in terms of the quality of the ward round, which is the key endpoint we were really interested in. We're not there yet on 1 or 2 things. And there have been some barriers, or rocks actually, and one of those is that we do struggle a bit with engagement from some of the senior medical staff, because this is about a complete change in culture in terms of how we do something. And if you've been doing this in the way you did it for the last 20 years, it's very difficult to really get to grips with how important this change is, especially if you think you're always right. The other issue we've had is we do have, although we've got a relatively constant stream of registrars because they tend to stay within the training programme for 7 or 8 years, there are an enormous number of pressures on their time, especially now with shortened training, well, short hours, so the training contracts are very constrained. So there is a real, it's actually tangible. You can tell when the registrar who's doing the ward round thinks he needs to be somewhere else. It feels rushed, it feels difficult at times. So one of our challenges is how do we get around that? How do we make the registrars feel like they've got the time they need to do this? So that's a big challenge for us. When they are pushed for time, they revert back to the old style of ward round because for them it's easier. And this comes back to what I was saying earlier about making this the easiest way of doing the ward round. Having said that, as I said, we've had some fantastic achievements. We have had, as Fiona said, 3 fully digital ward rounds with great outcomes. It has saved nurses' time and doctors' time, but it doesn't save time there and then. It saves time later in the day because the nurses are spending hours chasing around to find out what's going on with the patient. Same for the therapists, actually. They know what's going on, they just have to read it. We've had fantastic engagement, especially from the therapy teams, in terms of starting off by inputting the data and then adapting to the change to make it work better. We definitely have more timely medical decisions, and there's a much better team engagement on the ward. But I think probably the most important difference is that we're fairly confident that our patients feel significantly more engaged with their care. They're there at the start of the ward round, they understand that the ward round's happening, they're introduced to the ward round, well, not necessarily the individual doctor, and they hear the dictation of what's going to happen to them when that's done, which means they are far better informed about their care than they were when we were only spending 6 seconds. So, plan going forward, clearly, Helen, my name has got to be a significant part of that, and I'm sure we will get there eventually. We've got great engagement from all the teams. We're rolling this out, or plan to roll this out to the spinal team as well as the cranial neurosurgery team, spread it across both L24 and L25, and sort of continually audit and improve it as the technology and the EPM system catches up with our demand on what we really want it to do. We know we will get there, so I don't think that'll be a massive challenge for us when it does get to that point.
Thank you very much, particularly to Fiona, as well as to
Okay.
Steve. I mean, I think I've been to all of your report outs, and really this is your 6th one, because you did your RPIW and then 5 updates. And the persistence that you've shown and the resilience is brilliant, and I think it's really great to see that it feels like there's been a step change since you last report out. So thank you very much, and I'm sure there'll be lots of people wanting to know how you're doing all that. So we've got 2 more report outs now on value stream 4. Ophthalmology outpatients, and I think Danny and Deb are going to report out on the corneal clinic schedule.
Hello, my name is Deborah Hall. I'm the head of nursing for Clinic, and we chose to look at corneal clinic scheduling in order to try and improve our patient experience through that journey. They receive excellent clinical care from the staff in the clinic, but the clinics are often very busy, overbooked, they're complex, and in terms of the staff working in them, there's a lot of pressure and stress in order to meet the demands of the clinic and patients. So Danny is going to take us through the update here.
Yeah, so this is our 180-day report out, so we've been at it for 6 months now. As you can see on the projector, there's comments from some ophthalmology patients. Pretty much they have to wait, but the service they do get is great, which is what Deborah said. There's a lot of interruptions in corneal clinics as well, as you can see by role there. So there's a lot of junior doctor interruptions, optometrist, fellow consultant interruptions, which means the patient has to wait longer in clinic. This is what the interruptions are for. As you can see, the vast majority is for patient advice, supplies running around looking for things that are in the room. So some things we've done over the past 6 months that we've put in place and actioned. So we've created a production board because nursing staff weren't always sure who's in clinic, who's doing what, and contacts of the day. So they update that twice a day, the morning session and the afternoon session. That's a team agreement from the nursing team, just to say they know what it's for and to sign up to say that they're part of it. That's the original prototype of this production board 6 months ago. July, there it is in action. And September, as you can see, it's been tweaked and colour coordinated. This has been done by the nursing team themselves. Obviously, it's helping them arrange things even better. A lot of interruptions with the doctor leaving the clinic room to go get some equipment that wasn't there at the moment. So what we've done is we've put together a standard checklist of everything that could possibly need in a corneal clinic, and that's in action on the trolley. Also, a lot of the receptionists were interrupting the clinicians to sort out incomplete and illegible outcome forms for clinics, so what pathway, what the patient has next in his journey. So we created a tray which gets sent to the clinician at the end of the clinic for them to action. That saves on interruptions as well. And that's them signing up to do it. The one thing that we've not done, and we go into trial in November, is something called a resource consultant. So if you remember from that earlier graphic, a lot of interruptions were for junior doctors wanting clinical advice. So they'll knock on the door, they'll stand outside, etc. So what this resource consultant is we're going to have a reduced template on clinic, and they're going to go from room to room to see the patients and the juniors. dealt with any advice they've got. So juniors will still see the same amount of patients each clinic, as will the optometrists. The consultants will just halve theirs, so they can see a patient, move around all the different rooms, visit the juniors, see if they need any advice. That should save interruptions and patients waiting longer than they should do. That's Miss Anand, who's our corneal consultant, who's working on this week. We're going to use Kanban as a visual aid. So these Kanbans are going to go outside the consultant's room, so they can find out if they want a review of the patient, so the consultant actually go in the room and look at them. Or if they want to discuss a case they've just seen and feedback anything for any advice or info. The nursing team have agreed to give us a corneal nurse, especially for that week. So everyone knows who they need to go to if they need anything, a prescription, etc. So it should make things a lot clearer, and a lot smoother. So at the moment, the average time is 43 minutes and 45 seconds. So we've managed to shave 6 minutes off so far since we started doing this project, and hopefully this one will be the biggest impact. We're doing this trial on the week of the 19th of November, and we're doing it all week. Everybody's signed up, the consultants, the juniors, nursing admin. So hopefully in 30 days' time we can feed back to everybody and let you know if it's been a success or not. Thank you.
So well done. You've also been sticking with the process, and I know that it's not been easy, but I think you know from quite early on in your RPIW what you would like to achieve, and again you've stuck with it and you've made progress, so well done. And now we've got Batung and Chris, and you're coming to report out on your ophthalmology outcome.
Hello. Hello, my name is Batung, ophthalmology consultant, clinical lead. We did a form on ophthalmology outcome forms, and this was the background of this is that on average about 16 out of 143 forms were not returned to reception at the end of the clinic, which means 11% could not be processed. About 53% of the forms that came back would not have sufficient information to be disposed properly on the day, and there were varying processing times, which are very many hours, and sometimes they will be cached and therefore be processed months later. We had variations in the time taken to cache up one form, variations in the time to catch up batched forms, and then there was instruction of the nurses or the admin staff at the desk at the time when they could be processing forms. So the worry here is the patient impact, of course, of forms that have not been processed, where you have patients being missed out, and there is clear risk in ophthalmology and cycles. We had a rapid improvement this week in August, where we looked at the forms themselves. One of the decisions was to change the color of the form, make it very visible yellow, distinction from all the other pieces of paper that the patients have, so that they know what to hand in at the desk. One of the problems was information being filled in, and we felt that a lot of that was to do with the complexity of the form, that a tick in that might be a tick across 3 boxes, and there was probably too much on one form, so we simplified the form when 30 days with 2 forms in one clinic. My clinic's just using this simplified form to try and refine it over a period of time. We put up posters so everyone knew exactly what was meant to do, big letters on the back of the forms as well for the patients, so that they knew to return the forms to the desk before they left the clinic. We agreed with the respective physicians on how to fill in the new form. And this will be part of what happens with the form when we roll it out to the rest of the clinic. And these are essentially the results. The important bits are the lead time that had been 90 minutes that we managed through the improvement week to reduce to about 52 seconds. It's now down to about 44 seconds. That's quite substantial. The number of forms that are not returned to the desk, 11%, is now down over 2,869 patients to 2%, which is quite a substantial improvement again. Still a small number that don't come back, and we need to work on those. And then the other defect measure was forms that are not fully completed, where the team at the desk cannot make a decision or at least dispose of the form. That's down from 53% to 2%, which again we're really happy with. Clearly there's still some problems, and Chris will outline some of those measures for some of those problems. There was one other bit here which was trying to cache the forms on the day. Ophthalmology is a fairly big outpatient specialty in terms of numbers, and that has not quite been possible to achieve, plus the fact that one member of our team left about halfway through the project who was responsible for this, so we don't have full data on it. The results I've already mentioned are up here. Using the simplified or modified form, we had slightly less success in the numbers that were returned to the front desk. In fact, one can trace that to just one day. The rest of the time it was closer to that figure. But the bit that mattered with the simplified form was what we're trying to achieve here was better filling of information, better outcome information for the desk. And that's gone from 53% to 0.5%, which is again a significant improvement that to sustain. And we'll be looking at it for the period of time.
Barriers in thinking, first of all, the high volume patient capacity of the department, just assume that people agree to the attention for stays being made. As Mr. McKenzie said, the process of oversight and trust, which has left us short data, in particular the number of patients that were being disclosed after being seen, form applications required. We need an extra form to record things that fall outside the normal scope of the appointments, in particular patients that come to be seen for septic injections or for surgery. Simple vision was working well, in particular the yellow forms and the new format of the R205 being used to work with. These are items that came up in the process of dealing with R205s that were sent to the sentencing this year was no capacities. First of all, I'm divided between issues of communication with medical staff and also clinical staff. Appointments not being booked when there was space available, which is self-explanatory. Appointments beyond 3 months not being added to waiting list. That should really take place regardless, unless the person who's doing it doesn't have access to a particular waiting list. Next available points not being sent to capacity. Again, they should be booked given for open-ended. Points for claims that are cancelled. If the claim doesn't exist, they should be passed back to ask what should be done with them, or else look to the next closest date. Forms we've already looked again, self-explanatory, they should be coming up to the CSV. Written wills being ticking the boxes. That's probably the result of basically being
It's not quite as simple as it first at the beginning, is it? But have the patients responded well?
Yes.
Yeah, the patients finding it easier now to...
Just the very simple fact of turning the page to a yellow page makes a huge difference. They know what to do because often you give them a bunch of consent form copy and information leaflet, etc., etc. They know what to do with the yellow form.
Although I think Helen said you found it a challenge toward a yellow page. Okay, thank you.
Now,
Right, thank you very much indeed. Does anybody have any questions for any of the teams who've reported out? Because I think we've had a really comprehensive report out this week from value streams 3, 4 and 5. So I guess you may have some questions and we've just got about 3 or 4 minutes for them. David?
Well, it's more a comment thing on the neuro presentations. There's lots of really good stuff there, lots of advantages. And there's one advantage that I'm sure the team obviously would be well aware of, but maybe didn't comment this time. Getting that rehab prescription done so much sooner allows, as you said, the patient to go to that next step in their journey. But the elephant in the room is it also allows that next patient to come into the service. And I know it's obvious, but I think there's such good work that it's really important to stress it's for the patient in front of you, but it's also for the next patient trying to get into your service.
Yeah, we didn't sort of comment on it, but obviously we are one of the collaborative work streams that this came out of, and actually it is worth mentioning because this came out of the conversations around what can we do to make critical care flow better, and moving patients on to rehabilitation and repatriation is one of the things that we always talk about, and for a long time we felt it was going to be too big a thing to tackle. So there was quite a lot of conversation at the SST meetings around whether this was the right thing to do. Was it too big? Was it in scope? And I think what we've demonstrated is that it absolutely is in scope. You can make it work, and it can improve that flow. So don't step back from doing something that looks like a challenge at the beginning.
Okay, thank you. Jim?
A question for Steve again. Sorry, I just wondered with your ward rounds, have you separated the responsibility of the consultant doing the operation from the consultant who's looking after the patient in the ward, or is it still the same person? Because I guess in cardiology that was one of the big steps that we had to take. Somebody doing the ward rounds made the decision, I'm going here, I'm going to go and all the rest of it. Somebody did the procedure, nothing to do with the ward care. We haven't managed that in cardiac surgery. I'm glad you brought that up.
So, the consultant of the week, which is obviously the ward person, is a bit of a goal for the service. So we're moving very much more towards that spinal surgery. We're still not there for cranial surgery. So each individual patient still retains their own consultant oversight, and that has pros and cons. There's continuity, which is great, but unfortunately, unless that consultant goes around every day, that continuity isn't necessarily tangible. So I think that's a really valid point. We haven't solved it, and I think it's about trying to encourage surgical teams. And I know it's again, I've seen Richard leave unfortunately just before this because I know that for colorectal they've introduced consultant of the week, and it is working really well. And it's trying to encourage other surgical teams that it's not the wrong model to adopt, it can work.
And that's what I think.
Yeah, exactly.
Okay, thank you. Can I just ask, stick your hand up if you've never been in the Advanced Imaging Centre before? Okay, so, well, I hope you liked it, and now you know where it is. But can I just, well, first of all, thank all the teams who reported out, especially the neuro rehab team reporting out in front of the Secretary of State. I'm sure you might have felt a little anxious about that, but it was wonderful to show off both the method and the results. And well done for getting that slide in that showed the reduction. But also to everybody who I know changed their diaries to come here. I know some of you were reporting out anyway, but thought you were reporting out at St James's. And for those people who've never been to Report Out before, but came because we're a special visitor, I hope you've really enjoyed it and that you'll come again. Because although we've done a special Report Out today, it's like this every time we do it, and there's just as much great stuff every time. So, and the teams who are working hard, I know really appreciate both being able to tell their story and the discipline of having to report out, but also sometimes the ideas that they get from other people and some of your questions that help them to think about how they're going to overcome that next barrier. So thank you very much, everybody, and I'll just ask for a final round of applause. And